introductions. Thank you. Ranjit, please.
You can see my slides. Yeah. So good evening, everybody. So I would like to welcome all of you for the second session of the webinar on current concepts in management of the clubfoot. So for the sake of those who had not joined us last time, I would like to give a small overview of the program and a brief introduction of our faculty. We have our first talk on tenotomy of the tendon Achilles. It will be presented by Caroline Blakey, who is an orthopedic consultant at Sheffield Children's Hospital in the United Kingdom. Dr. Hitesh Shah, who is a professor in the Pediatric Orthopedics Department at Kasturba Medical College in Manipal, will be talking to us about bracing in club feet. Mohan Belthur from the Department of Child Health and Orthopedics in Phoenix, Arizona, will discuss common management errors in the treatment of the clubfoot. This will be followed by Alaric Aroojis. He's a consultant pediatric orthopedic surgeon at Lilavati, Hinduja, and Jerbai Wadia Hospital in Mumbai. And he's also on the medical advisory board of the Global Clubfoot Initiative. He will be discussing the tibialis anterior transfer in clubfoot treatment. Atul Bhaskar is a pediatric orthopedic surgeon at Surya and Bombay Hospital in Mumbai. He will talk to us about relapse and recurrence after completion of the primary clubfoot management. Finally, we'll have James Fernandes, a senior pediatric orthopedic surgeon from Sheffield Children's Hospital. He is the lead at the pediatric limb reconstruction unit here. And we will be hearing from his vast experience about his journey in the treatment of the multiply operated, recalcitrant, and syndromic feet by the ILLRS method. So if time permits, we could have clinical cases discussions after that. But right now, we'll begin the session. I would request Caroline to share her presentation so that we can begin the session. Caroline, you can.
Yeah. Good evening. Thank you for inviting me to speak again as part of the Clubfoot webinar. This evening, I've been asked to describe the tender Achilles tenotomy as part of the Ponseti method in the management of idiopathic congenital talipes equinovarus. So we talked last week about the pathoanatomy of the clubfoot deformity and the coupled correction of the varus hindfoot as the midfoot is carefully abducted around the talonavicular joint. But in the majority of cases, around 80 to 90%, there will be residual hindfoot equinus. It is imperative not to force the correction of the equinus, which will result in a rock bottom deformity. Correction of the equinus through the subtalar joint can be corrected only if the calcaneus abducts. Indication for tenotomy includes full correction of the cavus, adduction, and varus. This can only be assessed by the anterior process of the calcaneus becoming palpable once adequate abduction has been achieved and the calcaneus diverges from the talus. Abduction of approximately 60 degrees in the frontal plane should be achieved. The posterior os calcis should be a neutral or slight valgus, and the foot deformity should never be pronated or forcefully dorsiflexed. If any component of the deformity remains, we should return to manipulation and casting. In Sheffield, we use the Pirani score to assess the foot at each cast, and it's helpful to be sure that your midfoot is corrected and that your hindfoot score remains above 1 before Achilles tenotomy is performed. Preparation is critical. It's important to examine the child, as we've discussed, and make sure that we're at the correct stage for tenotomy. It's also important to assess the vascular status of the foot. The absence of the anterior tibial artery has been reported in clubfoot in more than 90% of limbs, and if the posterior tibial artery is also absent, the perineal artery may be the dominant artery to the foot and should be protected. it's important to think about the environment, that we tend to do our tenotomies in the clinic, and we do it in a room that's separate from the main casting area. We're able to have music on if that settles the child, and have a calm environment for the family. The family should be consented before the procedure, but this shouldn't be the first time they've heard about the tenotomy. At each point of meeting the family, we should introduce them to the concept of tenotomy and how it's going to happen. I tend to swaddle the baby on the top half and encourage the parents to have fed the baby beforehand. In some places, it's more appropriate for the family to go off and have a coffee and come back, but we tend to keep the family in the room while the tenotomy is performed. Make sure you have enough help. You need somebody to dorsiflex the foot and another member of staff to distract the parents. Have all your equipment ready beforehand so that the procedure is efficient and safe. The use of a 15 or 11 blade, I prefer a beaver blade, but there are other blades which may risk neurovascular injury. Local infiltration can be used. We use 1% lignocaine. Be mindful that local infiltration can make palpation of landmarks more difficult. Some prefer to infiltrate local at the end of the procedure to avoid this. Infiltrate just medial to the tendon, remembering to withdraw before infiltration. With the assistant holding the foot in maximal dorsiflexion, palpate the medial border of the tendon. Being aware of the anatomy with the neurovascular bundle antramedial to the heel cord, insert the tip of the blade from the medial side. Initially, keep the flat part of the blade parallel to the tendon edge before rotating the blade, bringing its sharp edge towards the skin and carefully posteriorly. A pop is felt when the tendon is released. If a pop is not felt, the tendon may not be fully released. In this clip, the blade was reinserted to release final fibers, and an additional 15 to 20 degrees of dorsiflexion should be achieved. The final cast is applied with the foot abducted to 60 to 70 degrees and with 15 degrees of dorsiflexion. The foot may look overcorrected and the parents can be reassured that this is normal. We apply the lower half of the cast first before completing above the knee. Complications include damage to the perineal artery, the lesser saphenous vein, and posterior tibial artery or the tibial nerve. Thankfully, these are rare, but it's important to be aware of the anatomy and perform the procedure safely and in trained hands. The final cast is held for 3 weeks. The family can go home the same day and advised to look for cast soiling and normal signs of cast slippage. At cast removal, the baby should be examined for full dorsiflexion so that it can be safely splinted and with the heels adequately down within the boots and bars. Thank you.
Thank you. That was really nice presentation and video. Any questions, any comments by any of the faculty members?
I have a question for Caroline. Thanks, Caroline, for a great presentation. A couple of questions. Recently, there have been some reports of using the needling technique. Hello?
Yeah, go ahead.
No, I had a question. Like recently, there have been some reports of using a needling technique as well as a semi-open technique for doing the percutaneous tenotomy. And the reason is to avoid sort of injuries to the neurovascular structures. So can you please say what's your opinion about these new developments and what precautions you take to avoid any neurovascular issues that may happen?
Certainly. I've read about the needling technique. It's not something that we use in Sheffield or that I have experience of. I understand the importance of trying to avoid injury to the neurovascular structures. I think if you assess the foot carefully before and take the precautions described, so entering from the medial side and turning the blade to rotate it towards you, generally I think you're safe. We do a mini open in an older child who's had a recurrence. So if I have a baby who's had previous tenotomies, then I would tend to do the procedure in theatre rather than in the clinic, and I would do it with a mini open technique. And I think the risk of neurovascular is higher in that situation. Perhaps somebody else could give their experience of the needling technique.
Thank you, Caroline.
Thank you. Yeah, sorry.
Yeah, can I ask a question? Ashish?
Please.
Hello. Yeah, so Caroline, that was a nice presentation. My question was, have you ever encountered in the OPD's basis any medical emergencies with the children, like breath holding or any medical problems while doing the procedure in the OPD, and how do you manage them at an OPD level? Do you require any support system, or do you keep somebody ready for a medical emergency, or it's never been a problem?
It's not something that's ever been a problem. We have a nurse around helping in the clinic room, and the room that we use has got oxygen and things should we need it, but it's not something that I've ever had to deal with.
Okay, thank you.
Okay. I have a question. What % of your patients, they need tenotomy? I mean, what do you tell parents? Because there seems to be a lot of variability between different centers.
So we actually audited ours a few years ago when I was a trainee, and a number requiring tenotomy was a bit lower than we expected. So it was about 70%. But I usually still quote the parents 80 to 90%. I tell them to expect to need it.
Okay, thank you. Okay, so thank you. That's very useful talk, and it clears a lot of doubts about the tenotomy.
Alaric, do you have a question?
I have a question, but I have a comment, if I may be permitted.
Yeah, please.
So, more about the point of using a needle, and I have a few strong views on that. I think we are surgeons and we should be comfortable using a blade, and we should leave needles for our medical specialists. I don't think in any way a needle is any safer than a surgical blade. And in fact, it gives you that false sense of security that you think you're making a smaller incision on the skin, but it can do as much damage if you're not aware of the anatomy inside the foot. So furthermore, I've seen that people who use the needle for a tenotomy have a very high incidence of an incomplete tenotomy. I've seen a lot of patients who have come back treated by others who have used a needle for the tenotomy, and subsequently I found that the tenotomy was in fact incomplete. So I don't normally recommend the use of a needle to perform this procedure. I think using a surgical blade, either a 15 number, or if it's a really small child, just using the tip of the 11 number blade is quite sufficient for doing a tenotomy. The other point I feel is that we should not hesitate in any way sometimes. If the child is very fussy, or if your setup has the availability of a good pediatric anesthesiologist to actually do this procedure under general anesthesia. So we routinely in our institute do not mind actually taking up these children under a short general anesthetic. You have some children, especially as they grow a bit older, who are quite fussy and in whom a local anesthetic does not work. And rather than struggling around with a child who's kicking and crying, it might be safer to take the child under a short general anesthetic and do the procedure. So I don't think the message should go across that it should always be done in the clinic under local anesthesia. There are circumstances where doing it in the operating room under a short general anesthetic, especially if you have the facilities of a good pediatric anesthesiologist, should not really be contraindicated this procedure. Thank you.
I would agree that certainly after 6 months, in the bigger babies that are going to fight you more, we would do that under general anesthetic, certainly.
Thank you. So we move on to the next talk, talk by Hitesh on bracing for the club.
Yeah. Ashish, can you see the screen?
Yes, we can see. Thank you.
Thank you for giving me the opportunity to share the experience. The task was given to me is the bracing in the clubfoot. So I am going to include the when should we apply the brace, what are the characteristics of the various braces available, what is the actual duration of brace the child should spend after the correction, how to check about the compliance, and how to make the parents convinced to continue the adherence of the compliance, and few points on the modification of the brace protocols. As we are all aware, the main management of the clubfoot is the correction of the deformity and maintenance of the correction. The earlier part and the last week we have discussed a lot about the correction of deformity, but in reality it is relatively short and most visible period where the parents will see the correction very quickly, but the issue will happen with the maintenance of the correction, and that is one of the essential component and the lengthier component that would be maintained by the brace, and where the parents are actually involved in the treatment of the clubfoot. Why we need the brace or the foot abduction orthosis, and very well reported by the Ponseti group by the Mercantor, said that without the brace the relapse rate of the clubfoot would be as high as 80%, and with the brace the relapse rate would be as low as the 6%. So it is very important to convince the parents that why we need to have the brace, because the most of the time the parents will feel once correction has been achieved, they say they're very happy and they are not stick to go with the brace. So it is essential to convince the parents that why the bracing is the essential part of the clubfoot treatment. The last week, Dr. James has mentioned very well that when to apply the brace, and it is very important to emphasize that it is essential to apply the brace only after the full correction, as it's mentioned by Caroline also. Once we achieve the 15 degree of the dorsiflexion after the tendon Achilles tenotomy, and what generally required immediately after the last plaster is out, we should apply the brace. And if the brace fitting is delayed, we do not hesitate to put one more plaster for another 3 weeks if it is a custom made brace or not a ready made brace. The most important component and the most controversial topic is there, which brace to use. There are the many foot abduction brace is available in the market, and if you see in the Western world, they use about the Ponseti or Mitchell brace, or that may be the Dobbs brace. In the Africa and Uganda, the developed brace is the Steenbrick brace, and that would be the very cost effective. When in India, it's a Pada Padma brace is also available. The Clubfoot Cure Clinic and Miracles brace are also important. I'm not going in detail about the various types of brace, but I'm going in the principles of brace. What is essential is there that each brace should have the accommodate the 15 degree of the dorsiflexion. The abduction bar should be equal to the distance between the both shoulders, and the brace should keep the both feet into 70 degree about abduction or external rotation, particularly in a bilateral clubfoot case. If it is a unilateral case, you can keep the affected side in the 70 degree of abduction and the normal side on 30 to 40 degree of the abduction. And if we are aware that we put the Ponseti, the last cast will have the 70 degree of external rotation, and that would be the same principle with the brace. When we see about whether the brace is competent or a non-competent, the first thing we need to check how much is about the external rotation of the brace. If we see about the brace and the amount of external rotation is less, there are the higher chances of the recurrence of the forefoot adduction, and that is the reason we insist we must have the 70-degree about the external rotation. So this is the one of the brace from the Ponseti group, the Ponseti himself, that would be the competent brace. But the very well good literature is there. The ankle foot orthosis or the polypropylene brace would not be as effective as the foot abduction orthosis. The reason being, this is a static brace that will not allow to have the dorsiflexion, and that can lead to the calf atrophy and the recurrence of the equinus. This kind of brace will have role in the syndromic clubfoot or the non-idiopathic clubfoot, but not in case of the idiopathic clubfoot. These are the incompetent brace for the clubfoot child. The few instruction for the parents that we need to teach that what should we apply, how to apply. The brace should be applied for the most difficult feet. It should be, hip and knee should be flexed. The hold in the corrected position and keep the foot heel first and make sure the heel touches the ground or the we can see about the medial side about the hole and check that the heel is properly fitting, and do about tying about the lace or strap depends on the brace, and once it has been fitted we can do the same on the opposite side. The physician can ensure that the well fit brace, because that the adherence to the brace would be depends on whether it's a well fit, the heel is touching the brace, that the foot is in 15-degree dorsiflexion and 70-degree of external rotation. The another component is there, what could be the timing of brace. This is one of the most controversial topics, but we are not going in the controversy. According to the Ponsetis, the brace should be wear the full time 23 hours in a day for first 3 months, and gradually weaning start as the child's developmental milestone would be achieved. And the brace would be maintained at least for the 12 hours in the night till the child reaches for 4 to 5 years. Again, it is one of the controversial 4 to 5 years, but the experience say the higher recurrence rate would be common up to the 4 to 5 years. So we should keep the brace till 4 to 5 years of the child. What could be the follow-up schedule? The earlier the brace fitting, we generally call for the week or 2 week, whether the patient is or parents are compliant to the brace, and see the whether is there any issue with the brace fitting or not. So the 2 weekly, then 1 month, then see about 3 months for 2 years and 6 months for 4 to 5 years. It is important to know what should be checked after the brace fitting, the age developmental milestone, whether there are the issues with the brace, whether it is fitting. As the child would be growing, it needs to be changed. When the child would be grown beyond the brace, the condition of the brace should be checked. And always check about the Pirani score, the range of motion, and the walking of the child, whether it is going to have the dynamic supination or not. The physician must be aware about the check about the Pirani scoring, whether it is getting worsened, whether any sign of the cavus, adduction, varus, and equinus is present, the child is walking, whether the callus formation is present, whether dynamic supination is present. Any of this would be present, we should discontinue of the brace and start treating like manipulation and casting. Till what age a child should use the brace? Again, say there is a poor literature on this topic. Randomized control trial would be needed, and I know that there are the few centers have started this. We'll get the answer soon. The few points, to change the brace protocol, that depends on the age of the child after achieving correction. What we said about 23 hours in a day in infants, but if child starts walking, it is practically very difficult to keep the child with the 23 hours in a brace if you correct 3 years or 4-year-old child. Whether it's idiopathic or non-idiopathic like multiple congenital contracture, it is very difficult to get fitted this brace. The ankle foot orthosis would be okay. A few points on the atypical clubfoot. Atypical clubfoot, we do not rotate so much, so the external rotation would be less in case of the atypical clubfoot. Presence of ligamentous laxity, it may go for overcorrection, so we can reduce about external rotation. And again, I have already mentioned unilateral and bilateral clubfoot. In that will be the same the older child's only nighttime or the AFO would be okay in case of only in older age group, and gross ligamentous laxity, the less external rotation is required. What is required in the future, we can see about the child's comfort and patient's adherence to the parents' adherence to the brace, and it should be available. I know that some part of the India, the braces are not available, so we can see about the cheap and easily available. And again, we need to generate the good, high quality evidence to know about the effects of the brace, clinical and functional outcome, and actually we should know about the timing of the brace. In short, the bracing is the key part of the clubfoot management. Compliance to the key for the higher success rate. Careful follow-up is required, and strict implementation of brace protocol for the correction and maintenance of the correction to prevent the recurrence, and adherence to the brace protocol is the main factor for the long-term success. Thank you.
Thank you. That was a great talk. Any questions by any of the faculty members? Or...
Yeah. Hi, Hitesh. Thank you for a great presentation. It's Mohan again. I have a couple of questions. And one thing was, in my practice, I see a lot of children with birth defects, especially children sometimes with longitudinal limb deficiencies like severe fibular hemimelia, uh, tibial hemimelia on one side and an idiopathic clubfoot on the other side. And then some of them end up having like a Symes amputation or something like that. So my question is, how do you manage these patients? That's one question. The other one was also some of them may have like a phocomelia or something of one limb where they don't have, or the other, the normal ankle, for example, or the clubfoot ankle is normal, but the other side is above the level of the knee. So in those cases, I find it hard to use the Ponseti-Mitchell brace. So how have you managed these patients? Thank you.
Yeah, Mohan, it is a great question. The limb deficiency, associated limb deficiency and clubfoot is the complex clubfoot. And I think as I mentioned, this brace protocol is only useful for the idiopathic clubfoot. What generally we manage with the non-idiopathic clubfoot depends on the correction. If the child is not of the walking age, we can use the ankle foot orthosis. And if the child would be walking, and if the opposite side is not normal, then if the child would be after walking age, we can prescribe about the old Dennis Brown shoes, and we maintain the correction. And we generally teach those kids parents the passive manipulation. And actually I generally believe on the passive manipulation, so it will not tend to recur, particularly if we are not external rotating about the 70-degree. We teach them to stretch about the forefoot adductors, so to maintain the correction. I think James will give you the comments on the limb deficiency better.
Yeah, I think I'm going to touch on it later on in my talk. And okay. I've seen many of these in my career. Now remember, these feet are not club feet. They are birth defects.
Yeah.
It might look like a club foot on the contralateral side. They might have coalitions because, as you know, 25% of fibular hemimelias have varus feet. The commonest is valgus feet. So I might try the Ponseti method, but I always will look at it in a different way and modify the principles depending on what the morphology of the ankle is and so on, how many ray foot. So they don't actually, I do not consider them as club feet at all. That's one. Now you did mention about one side having a foot at the knee level. We have designed bracing in such a way that you brace one side on the femur and then do a kind of bar to keep the legs abducted. So you can speak to your orthotist to modify it. But these are all syndromic, and there are only a few ways you can treat properly by Ponseti, but most of them you have to modify something or the other, and they do not work the same way. So I will touch on that quite a bit later on about it as well. Yeah.
Thank you for your comments. So my question, if I was not clear, was sometimes you have an idiopathic clubfoot on one side. I was not asking management of the opposite side, which is the syndromic clubfoot. So in my experience, what I have done is I've used the ADM brace, which is the abduction dorsiflexion mechanism brace. It's been reported in small series, I think, from the UK. But long-term results are not available. And I've used them, especially if the child has had an amputation on one side or has a focomelia or something like that. And at least in the short term, I seem to have good results. But long-term results, I don't yet have. Thank you.
Mohan,
the other question,
Mohan,
yeah.
Sorry, Mohan. I think they are all birth defects, according to me, because it's all happens between the 4th to 8th week kind of concept. They're not actually, so I possibly will treat. I've used the ADM brace as well, but they do not behave the same way with like the rest of the classic idiopathic club feet. That's what I'm trying to say.
Okay. And then the other question for Hitesh was, some children, as they grow and start walking, sometimes they develop a lot of out-toeing on the normal side, for example. In that case, would you consider reducing the amount of abduction on the normal side? Is there any relationship? What are your thoughts?
Yes, I agree. In case of the gross ligamentous laxity, or the patient is developing the valgus or the fixed external rotation, we reduce it to not the 70 degree to the 30 to 40 degree. That is reason I have included the important aspect to assess the age, ligamentous laxity, its outgoing, the external rotation, and the normal side. There we have to reduce and particularly atypical clubfoot, because in atypical clubfoot also we have to reduce it. Otherwise, that will develop about in extending of the gait.
Thank you, Hitesh.
Yes, Atul will say something.
Yeah, just a point, Hitesh. Have you noticed any children coming back with the lateral subluxation of patella or patella malalignment post bracing? I've had a few children where I had to actually, undo the bracing. So, you have any experience or any
In fact, Atul, that is a very good question, and that's a good observation. And some of them I have picked up that with congenital dislocation patella, where it goes with the external tibial torsion also. So yes, you are right that the few kids not all the kids will have the congenital dislocation patella, but if it is going to develop about the external rotation, and that is the reason follow-up is very essential. We generally call in 2 weeks, then 1 month, then 2 months. So if any times they develop about the external rotation, we have to change our brace protocol.
Hitesh, there is a question from audience that should we use AFO in a walking child? And other question is, what are your thoughts about CTEV shoes or tarsopronator shoes, which are commonly used in India?
Yeah, that was the usual traditional practice, and in fact, we were also involved in this practice for the long time. But its essential component, it is very difficult to keep the walking child into the pauncity or the foot abduction brace so the initial part when we want to maintain the correction, yes, both would be useful also immediately after the plaster if the child would be older enough and will not use about the foot abduction brace. Yes, that would be having some role to maintain, because that will prevent the recurrence in all three directions. That will not go for the cave deformity again. So that's why it is essential to use. It is something is better than nothing. So yeah.
About CTV shoes, tarsopronator shoes, do you use it? What's your take?
Yes, the similar principle, the original the tarsopronator or the CTV shoes that is called as the Dennis Brown shoes. That again essentially it is for the walking child when there would be not heel, the forefoot, the medial straight and stiff. There's a tarsopronator, so it will be also useful when we achieve the clubfoot correction in the older child. So if we can get about the Dennis Brown shoes, I don't think so it is useless. It would be useful where the child can because after the plaster removal, I think I like to keep the child in brace for at least for the 3 months to 6 months, till that it will for 23 hours. So if the child would be walking, and if we use the foot abduction brace, the child will not use for the at all, then we can modify it. We can use the shoes in daytime and the nighttime into the brace. That would be okay.
I would like to make a comment.
Yeah.
Yes,
The
please.
Concert International Association has recently designed a new brace. It's called as the Iowa Clubfoot Solutions Orthosis. They've trialed it over the last 2 years, and they have started using it in Pakistan, Bangladesh, Sri Lanka, in China, as well as in the US. So it's produced in China, and it's at very low cost, and it's run by the Concert International Association and another sister organization, and it's very available at low cost, and all over the world they get the same brace. It's shown to be very comfortable, and that's what matters to maintain compliance with bracing. One of the main things is comfort of the brace. So I just wanted to let you guys know that this low cost option is available, and if you guys are interested, you can get in touch with uh, Jose Marquende. Thank you.
Thank you. Thank you. So I think we move on to the next talk. Mohan Belthur is going to talk about common management errors. Mohan, please.
So good morning, everybody. Thank you for inviting me to again share my experience and thoughts with you all. As you all know, Ponseti method Can you guys see my screen?
Yes,
Hello?
we can say it.
Yeah.
Yeah.
So as you all know, the Ponseti method is a very specific and precise method, and involves an initial period of casting followed by tenotomy and bracing to correct the deformity and maintain the deformity. So my charge is to talk about what common errors we do while taking care of these children, and hopefully give you some thoughts about how we can kind of address them. So I think before we do that, we need to understand why we kind of run into these errors. I think the definition of an orthopedic surgeon that Mark Wendet told me one of the times I visited him was this: it's someone who modifies a procedure the first time they try it. So this is one of the main reasons why we run into these errors, problems, and obstacles. So we try to modify the method. We think that it's very easy and we know everything about the foot, and we can modify it easily and it's going to work. But as I told you, the Ponseti method is a very precise and specific method. So if we don't pay attention to the details, then we run into problems. This was also revealed in a recent systematic review from China that was published in the CORR, that attention to detail is very important to prevent errors and mistakes. Now, I would like to sort of group the errors we run into, or the problems we run into four periods. Those we run into while manipulating the foot before casting, those we run into during the casting phase, those we run into during the tenotomy phase, and those that we encounter during the bracing phase. Obviously, if you look at the, if you count the errors or look at them, most of the errors are encountered during the bracing phase, but we do encounter errors in the other phases too. And also, like Hitesh already pointed out, the bracing is for a long time, up to 4 to 5 years, as you know, that's been recommended. So the chances for running into problems is higher during that period. Now, let's talk about what problems we encounter during manipulation. I think the first step in the Ponseti method is to elevate the first ray to supinate the forefoot and put it in the same degree of supination as the hind foot. So pronating the foot is probably the first error we encounter. So if we do that, then it's going to lock the midfoot. If we pronate the foot instead of supinating it, means instead of elevating the first ray, as shown in this picture on my left, if you supinate the if you pronate the forefoot instead of supinating it, you kind of lock the midfoot and you won't get good correction. So this is how the cast should look when you supinate it. The forefoot and the hind foot should be in the same degree of supination and do not pronate. The next error that we run into is during the next step. That would be forefoot abduction and hind foot varus, which we are correcting at the same time using the calcaneopedal block principle. Is by putting the thumb over the calcaneocuboid joint as shown in this figure on my right. This is called as Kite's error. So Hiram Kite was more vocal than Ponseti and advocated this method and did not have as much success as Ponseti did. And many of the feet resulted in having surgery or posteromedial release because of failed correction after that. So just moving the thumb like 1 centimeter from the calcaneocuboid joint to the lateral talar head here would allow the calcaneus to move and prevent this mistake. Again, you will have inadequate correction if you do this. The next thing is, while doing the same maneuver, it is very important that we do not restrict the calcaneum by putting our hand, as shown here in the picture on my right. If my hand is here holding the calcaneus, it will not allow it to go into valgus or abduction and prevent the correction of both forefoot adduction as well as hind foot varus at the same time. So that's another error that we commonly run into. And the next error, as we continue with the correction of the forefoot adduction and hind foot varus, we sometimes do not abduct the foot fully. So in his initial series from 1948 to 1963, Ponseti did not abduct his club feet to more than 50 degrees and had a slightly higher recurrence rate as opposed to his second series, which he published in, I think, 1973, where he had introduced abducting the foot to 70 degrees, which we now do. And this stretches the posteromedial structures and reduces the risk of relapse. So that's another thing. So you need to abduct it to this degree. The normal degree of abduction in the neonate or infant foot is about 40 degrees, but you need to take it to about 70 degrees to stretch those posterior and medial structures. And the final cast should be in that position. The other mistake that we also do is trying to push the foot into dorsiflexion too early, or not dorsiflexing it at the ankle, but more at the midfoot level, especially if your fingers don't reach the talonavicular joint all the way. And if you're just holding the tip of the forefoot, you can create a midfoot break and what we call as a rocker bottom foot. And also it's important that the foot is abducted at least to 50 degrees or so before trying to bring the heel up into dorsiflexion or the ankle into dorsiflexion. Now we will move on to some of the errors we see during the casting process. These are listed here, and I'll explain in the next slides. The first thing is it takes two people to cast. So if you don't have the correct setup, or if the child is not fully relaxed and distracted, as shown here, then you run into problems because the child is moving all over, they're crying, the leg is moving. So when you apply the cast, you may not be able to position it in the way you want it. And also the cast you may get wrinkles in the cast, which may cause skin issues later on. So it's very important to have a holder and a casting person. So if your casting tech is experienced, they can do the casting and you can just hold. But if you have somebody who is not experienced or you're training them, then they might have to hold the foot while you cast. Other important thing is to ensure that the child is not fed for about 2 hours before the casting, and is fed while the child is being casted. This way, the child is not distracted, so the child is distracted and is quiet, calm, and you can go ahead with your casting process. And also, it's important to have the mother in the room so that she can talk to the baby, whisper to the baby, touch the baby, etc., which will again calm the child. Another important thing is to have a room which is quiet and not do it in a busy casting room where multiple fracture patients are being casted and the casts are being removed with a saw. There's a lot of noise. This can again cause anxiety and and make casting difficult. So that's important. Again, distracting the child is important. For example, this is especially so in the older child where you may not be able to distract the child easily with feeding them milk. So you may have to use other techniques. In this picture, you can see Fred Dietz, who used to be partner with Jose Marquende, and also one of Ponseti's students and my teacher as well. He is distracting the child here using a flying helicopter. So that's important. Or Ponseti also says play music, like he used to play Beethoven in the casting room, to keep it quiet and calm. So those are things that would be important. Another thing is not holding the foot in the corrected position while casting. These two pictures show how the foot should be held in the corrected position. This is probably, I think, the second cast where you see the foot is in a neutral position. If you put the cast and then try to correct it again, you will cause wrinkling in the cast and you may not be able to get full correction or put it in the position where you want it. And again, this can cause skin issues later on. Also, other things are poor cast padding technique as well as casting techniques. Here, Marquende is demonstrating how to hold the Webril. That's what is the preferred cast padding material. He holds it between his, the middle finger on the thumb and stretches it a little bit, not a lot, but stretch enough so that it doesn't tear. But at the same time, so too little and too much stretching is not good. So he's demonstrating that in this picture. And also a poor casting technique. So it's very important to move the hand and do the molding while the cast is wet. It's good to use rapid setting gypsona and some lukewarm water so that the cast sets quickly. It doesn't take a long time. At the same time, what Ponseti is showing here on the picture on the right is molding above the heel, so as to prevent the cast from slipping. Another thing that Marquende and Ponseti both insist is tight application of the cast padding such that there is no space either between the cast padding and the foot or between the cast and the foot, such that the cast is more conforming, not constricting, but more conforming. So it's not like a plaster cast. So, and also mold the cast, and the knee should be flexed to 90 to prevent the cast from slipping off. And in some cases, you may need to do a quadrilateral mold of the thigh. So these are all, sometimes, I think last time we also touched upon it, use some tincture benzoin. If they have a lot of equinus in the ankle, the cast may again slip off. So to prevent the cast from slipping, you can do those things. Again, keep your fingers moving around. If you keep them in one place and use too much pressure, you may end up with something like this, which is a pressure area and skin breakdown over the lateral talar head. So you don't want that, because that makes the child uncomfortable and makes the molding process painful, and you can't get a good correction. Again, applying below knee casts. You can see these casts have too much padding. They don't go above the knee. Again, they fell off as they are documented here very soon, within a day or two after the cast was put on. And also, normally, the cast should be taken off on the morning of the next cast. If you allow the parents to take them off before, you will lose some correction, and you will have to go back a couple of steps. So it's important to take off the cast on the same day, in the morning off, or in the casting room before you do the next cast. It also allows you to look at the cast and see where you were last time, so that you can make progress. Another thing during the casting process that I've seen is the mothers are kind of become very emotional. They start crying. They're sad. They are in this postpartum period where they're susceptible to being very emotional. So it's very important to be compassionate to them, show empathy, and stop what you're doing. Mention or acknowledge their emotions, and because this will allow better compliance with the treatment protocol, and that's been shown in this paper recently, and that's been my experience as well. Next phase would be during the tenotomy phase. These are the errors that we make, and again, I'll explain them in the slides. I normally use like topical prilocaine ointment, or what we call MLR cream, as you can see in this picture on the left, and leave it for about half an hour before I do the tenotomy. I don't inject too much local anesthesia before, like Caroline already alluded to, because this will distort the anatomical landmarks and may make identifying landmarks difficult. But I inject local after the tenotomy is done. Another thing is doing a tenotomy which is very low. The ideal position would be 1.5 centimeters above the os calcis tuberosity, 1 to 1.5 centimeters. The reason is this: look at the anatomy on this picture on the right. The tendon achilles expands as it goes down and inserts into the calcaneal tuberosity, and the chances of doing an incomplete tenotomy are higher if your tenotomy is lower than 1 centimeter or 1.5 centimeters from the top of the calcaneal tuberosity. So that's the reason why Ponseti said tenotomy should be at that level. Also, incomplete tenotomy is common, especially if you're training a fellow or a resident. So the things to look for, I usually use this look, listen, and feel that Professor Saleh taught me in Sheffield, and Dr. Fernandes taught me in Sheffield while doing an osteotomy, but I use the same principle here. You look to make sure that you've dorsiflexed the foot to more than 50 degrees, say from minus 10 degrees of ankle equinus. You listen for the pop that Caroline also mentioned, and you also feel. I use a hemostat before and after the tenotomy to make sure that the tendon achilles is completely divided before I put my monocrystal stitch or just put a steri-strip. I usually use a single monocrystal vertical matrix stitch to close my incision and check for completeness. So this is especially important in the older child because you can run into problems of incomplete like tenotomy. So look, listen, and feel is important. And if you have the ability to use a C-arm, like Dr. Harzenberg has a C-arm in his clinic, so he can check for ankle dorsiflexion before and after completing the tenotomy in the clinic. So I don't have that facility, but if you're doing it in the OR, again, you can check that. So it should look like this. So before, you can see the ankle equinus is about minus 5 degrees or so. You can see it's about 15 degrees here. So that's how it should look. The next thing is running into neurovascular structures. As you can see here, this is a picture of the leg, the posterior aspect of the leg, looking of the left of the right leg, looking at it from posteriorly or from behind, and to my left or to the picture's left is the medial side, and the lateral side is on the lateral left side is on the right side, or the lateral side is on the right side, medial side is on the left side. And as you can see, it's very important to start the tenotomy from the medial side, because that is the unsafe side, because the posterior tibial artery neurovascular structures are there. There are also neurovascular structures on the lateral side, like the sural nerve, peroneal artery, short saphenous vein, but they are less critical. And if you were to choose one side, I think the medial side would be more important to preserve. So if you start your tenotomy on the medial side, you can control where you go. So therefore, it's important to start on that side and end up on the lateral side. Also, during the tenotomy, I use what we call as a beaver blade, which is a cataract knife, which is shown here in green. This knife is very small, and it has got one sharp end and one blunt end. And it's less than 5 millimeters the tip is less than 5 millimeters in width. So you can easily use it, and it makes very little scar. You should not use this sharp edge knife as shown here in B, which is likely to injure as you go in the structures on the lateral side or sometimes on the medial side. Okay. The risk is if you damage the arterial or venous structures, especially the arterial structures, it may bleed to some extent during the procedure, but it may also result in a pseudoaneurysm later on, as has been reported by Dr. Ranade and Dr. Herzenberg. And as shown in this picture, it can result in the formation of a pseudoaneurysm. This is a case I've borrowed from their paper, where it shows this child who later on developed a pseudoaneurysm. As you can see here, you can see the swelling on the left leg compared to the right leg. And this is the ultrasound picture showing the pseudoaneurysm here coming from the peroneal artery. So recently there has been some publications which have used some techniques to improve the safety. For example, this is called as a posterior-anterior control technique, where after making the incision, they use a hemostat to protect the tendon achilles, to isolate it, identify it, and then protect it and doing the tenotomy over it. I think that's safe to use, especially when you're teaching somebody like a fellow or a resident do. The next group of errors we encounter are during the bracing phase, and this is the most important phase of the treatment protocol. And the main one of the errors that we use is failure to use the foot abduction brace. So if you use other kinds of braces, then you won't get the dorsiflexion and abduction stretch that you need to get to prevent recurrence, as recommended by Ponseti. And this is how the brace should look. This is the Iowa Clubfoot Solutions orthosis that I use. And this is one of the most common causes of recurrence or relapse. Second thing is trying to fit a square ball into a round peg hole. Okay, for example, if you try to foot that is not completely corrected, either not completely abducted or completely dorsiflexed into the brace, you will run into problems of skin irritation, skin breakdown, redness, etc. As shown in this picture, this is what happens. Something has to give. So recently, I think there have been a couple of papers, I think Agarwal et al. Have published, where they extended the Ponseti protocol after the tenotomy is done in the postoperative period. Don't hesitate to put a cast on, or 1 or 2 casts, to improve your ankle dorsiflexion if you are not able to achieve it during the tenotomy. This is especially true when they have a lot of ankle equinus before you started the tenotomy. For example, in some of my cases, especially atypical club feet, you may have like minus 40 degrees or minus 30 degrees of equinus, and just the tenotomy alone may not be able to get you to 15 degrees of dorsiflexion. So there you may need to do a couple of casts after the tenotomy is done to achieve some more ankle dorsiflexion. So that's important. Another thing is poor brace design. Like Hitesh alluded to earlier, there are different kinds of braces. And the main important thing, the design feature that the brace should have is comfort. And it should accommodate the foot. If the brace does not provide comfort, then you run into issues with brace intolerance, that the child can't sleep at night, parents are having difficult issues at night. It can also cause issues with the foot as shown here. Usually, the redness on the anterior aspect is because of too much, a lot of tightening or excessive tightening of the anterior strap. And the heel posteriorly is mainly because inadequate tightening of the heel, or therefore the foot begins to move to some extent in the brace, and that causes friction and causes this irritation in the back. And this is one of the main causes for brace incompetence or brace intolerance as well. Other errors, communication errors. Recently, there was a paper from Bangladesh which reported they interviewed all the parents and families who had brace intolerance or non-compliance and asked them, like, what were the reasons. They were trying to find out what the reasons were for loss of compliance with bracing. And the parents said poor attitude of the physicians or the healthcare provider team, lack of empathy, criticizing the parents for not being compliant when they're trying their best to do trying to do their best for their child. So showing some empathy to them, listening to them first, dancing with them, guiding them, and then trying to influence their behavior. That's what is likely to help. So you must engage the patients and the family, educate them, enlist their help, and then empower them rather than blaming them or criticizing them. So if you use good communication skills and take some time, then and especially in families who have low health literacy and where the parents are separated and both parents are working, it's very important to do this. So I use this READ method, which is called relationship establishment, development, and engagement method, which is one of the foundational skills in healthcare communication, developing a good relationship and showing empathy to do this, and also share decision making with the family. Okay, these are all things that would help overcome this. And lastly, failure to understand socioeconomic determinants of health. They account for about 30% of brace intolerance. For example, they recently, again from the Bangladesh Clubfoot study, the Pansati International Association and others have come up with this parent load factor sort of classification that they use. So if they score high, like using the Pirani score, which has 6 factors, they put in these 6 factors that are important to ask, which are social determinants of health. For example, what kind of house do they live in? How far do they live from the clinic? And then what is their educational level, the parents' educational level? Are they single, means are the parents divorced, etc.? And then do they have a cell phone that works? And then how many other children do they have? Means do they have enough time to take care of this child? So based on this, you can use this scale. It's rated similarly from 0.5 and 1. And if they score high, 4 or above, then that shows that these families are likely to run into problems with brace compliance. So I've started using this score. This was recently published in 2020. So you could consider using this score in your clinics. So in summary, most idiopathic club feet can be treated well with the Pansari technique, and the posteromedial release is not necessary in about more than 95 to 98% of kids, and bracing tolerance can be achieved definitely in more than 2/3 of the families, and with some effort in the remaining 1/3 of the families. Thank you for your attention.
Thank you, Mohan. That was a very comprehensive, extensive review. Any comments? Mr. Fernandes, any comments, anything you would like to add?
No, I think Mohan has covered quite well everything. Absolutely, no doubt about it. I think like the last comment he made, I think surgery, open surgery needs to generally go out of the system in in the management to come and mention briefly later on. But I think overall, I think he's covered all the points.
Can I ask a question, Ashish?
Please, sure.
Well, that was a nice presentation. I just wanted to know, have you encountered any iatrogenic rock bottom feet, and what is the protocol you follow for these conditions for your treatment?
Yeah. Yes, I have. Mostly from referrals I see from podiatrists, because there are a lot of podiatrists in the US who read about the Ponseti method and start using it without, like I said, paying attention to the details, and also sometimes from other orthopedic surgeons as well. And so it's called, and then Mark Wende and others have reported on it in 2005. This is one of the main causes of the complex clubfoot. You can, but they call it the smashed foot. So when I see these children, it's usually they've had 2 or 3 casts and the foot is swollen. And so what I do is I stop casting at this time to allow the swelling to go down. And if there is skin breakdown issues, for those to heal. I then talk very carefully to the parents and explain to them what we will do, that we would have to restart the casting process after allowing the foot swelling and the skin issues to resolve completely. And then start off from scratch very carefully. And if sometimes there is a lot of equinus, like I said, in the atypical clubfoot, I do not hesitate sometimes to do an earlier tenotomy, as reported by Van Bose et al. Previously, and I've had pretty good success in managing these feet. Does that answer your question?
Is it the protocol for casting is the same after that, or you need to wait? That is what.
Yeah, means you definitely wait until the swelling and the skin issues settle. The other issue that you may need to pay attention is what we described in the manipulation technique during the last weekend was the Ponseti 1 protocol, which is mainly used for idiopathic club feet, which are typical. In the atypical or the complex club feet, you may need to use the Ponseti 2 protocol. I don't have the slides up here, but that would be another talk. I'm not sure if like one of the other speakers is going to talk about it, but essentially you change the positioning of your hands such that you're careful when you abduct the foot, and also paying attention not to exacerbate the midfoot break that's already been created. So the positioning of the hand is very important there. Again, both the videos are available on the Ponseti International Association website, and I'm happy to share with you guys if anybody is interested. So use the Ponseti 2 protocol as well. Thank you.
Thanks.
Okay, so there is a question from Dr. Singh from Himachal Pradesh. How do you choose which brace to use? Suppose if you have all types of braces available, how do you decide?
I think the 2 main deciding factors are comfort and cost. Okay, so like these days, there is a lot of discussion about adding value to the healthcare. That means improving quality while reducing cost, while improving patient experience. So you want to improve quality and patient experience at the same time, reduce complications and cost. So the brace that provides maximum comfort and allows you to maintain the correction, and at the same time is low cost, that would be my choice of brace. Like I said, the Iowa Clubfoot Solutions brace has been recently introduced over the last 2 years, and it has shown that even compared to the Ponseti-Mitchell brace, which was also developed by Ponseti, this is a modification of that, and taking into account the biomechanical principles of the foot. This allows, it uses a flap on the dorsum of the foot instead of 3 straps like in the Ponseti-Mitchell brace, and it has significantly improved the comfort of the foot, such that they are going to come out with this paper, Mark, when they interviewed 1,000 families who have used this, and also they have compared it to a control group of patients who had used the Ponseti-Mitchell brace previously. About 30% of patients with the Ponseti-Mitchell brace ran into issues with comfort, resulting in redness, either anteriorly because of too much tightening of the middle strap, or the heel redness, while the number of people who have had these issues with the new Iowa Clubfoot Solutions orthosis is hardly less than 1 to 2%. So that's been my experience as well. I've been using this over the last year. And also it is low cost. For us, it is cost equivalent because it's a non-profit organization. So we get it at the same cost as the Ponseti-Mitchell shoes were being sold at. But for countries like India, Sri Lanka, Bangladesh, China, it's made available at very low cost, like South America. And I think the cost is variable from country to country, but it's cost $10 to make. It's made in China, and it's provided at a very, very nominal cost to families all over the world. So the purpose of Ponseti International Association is not to make money, but to provide, to allow the Ponseti method to be used all over the world and improve the care for these children all over the world. At the same time, adding value to care. Does that answer your question?
Yeah, thank you. So thank you. We move on to next talk. Alaric is going to talk about tibialis anterior tendon transfer. Alaric, please.
Yes, thank you, Ashish. So I think you can see my slides and you can hear me clearly.
Sorry, your voice is breaking, Alaric. Not very clear over here.
Okay, is that clearer now?
Yet, Ashok.
My voice is very clear. Is that still the problem?
Not clear yet. It's breaking.
Okay, maybe a problem with Wi-Fi. Let me try something else then. Sorry. Hello, can you hear me?
We can hear you, sir. Is there any problem with sharing?
No. So I was just thinking about the audio first. Is the audio okay now?
Yes, sir. It's okay.
Yes.
Okay. And can you see my slides as well?
Yes. Perfect.
All right. Good. Thank you so much. So today my brief is to talk about the tibialis anterior tendon transfer. And this is a very specific sort of surgery done for a specific type of recurrence, which is a dynamic supination deformity. So in today's talk, I'm not going to focus too much on the early recurrence following the Ponseti method, which I think will be following in the next talk by Atul Bhaskar, where children recur in the first 2 years following treatment. And that is mostly because of the failure to obtain full abduction in the last cast, and also because of non-adherence to brace wear, which has been talked about in the previous presentations as well. But I'm going to focus more on the late recurrence, which typically occurs between the ages of 2 to 5 years. And one of the important things here is that dynamic supination is an important component of that recurrence. We must always understand that dynamic supination can exist by itself, but it can also be part of a static deformity which has recurred as well. So before you correct dynamic supination, you must be aware of the fact that if there is a static problem, you need to go back again to Ponseti casting to correct any residual static deformity. It has been shown by Ponseti and by several other authors after that, that any recurrence that following the Ponseti method is quite amenable to repeat casting. And if dorsiflexion has been lost, then again to do a repeat Achilles tenotomy, especially if the dorsiflexion is less than 10 degrees. Occasionally, you have children who have recurrence of the cavus as well, and you can sometimes try with a couple of plasters, but if that does not work, I have no hesitation in recommending a plantar fascial release as well to treat any rigid cavus that occurs as part of the recurrence in the older age group. And finally, to treat the dynamic supination, once the static deformity has corrected, then to go ahead doing a tibialis anterior tendon transfer to the lateral cuneiform, and that's what I'm going to be focusing in this particular talk. So as you can see, the tibialis anterior tendon transfer is not a new procedure. It's been described more than 80 years ago by Garceau, who reported his results in about 44 patients and was highlighted in this paper again. It was published in JBJS 1952. So what I'm going to do is show you a bit of the surgical technique, a few steps of how it is recommended to be done, and hopefully give you a few examples from literature on the role of the tibialis anterior tendon transfer for treating dynamic supination. So here's a video of the tibialis anterior tendon transfer technique. And I'll begin by showing you a typical case where this is a 3.5-year-old boy who presents with a dynamic supination recurrence. And as you can see, this is a typical presentation where the child walks on the lateral board of the foot. During the swing phase, you can see that the tendon is taut. So here's the skin marking. We use a 2-incision approach. The first incision is on the dorsomedial aspect of the foot, mirroring the insertion of the tibialis anterior tendon, which goes into the medial cuneiform. So here you can see I'm releasing the tendon sheet over the tibialis anterior tendon. It's going all the way down to insertion onto the medial cuneiform and the base of the first metatarsal. It is a broad insertion, and it's important that we track and trace the tendon all the way down to its insertion so that we get the full length of the tendon for the transfer. It's very rare for this tendon to fall short, but it's worthwhile taking a little extra time in harvesting the tendon properly. And as I've shown you, once you have got down to the insertion, you can see that I'm now disinserting the tendon by sharp dissection, right from its insertion onto the medial cuneiform and the base of the first metatarsal, as you can see there. Once that is done, the next step is to free the tendon sheath. It has some attached vinculae. Go below the extensor retinaculum. As you can see, I'm preserving the extensor retinaculum. We must be careful not to release the extensor retinaculum because that's what's keeping the tendon from bowstringing, but release the tendon sheath enough so that you get a free play of the tendon. The next step is take a stitch through the tendon. You can take either a modified bundle or a whip stitch. I prefer doing this rather than an extra tendinous stitch like the modified Krakow, because I find that an intratendinous stitch is useful so that the stitch does not snag into the bone tunnel that we're going to be making in the lateral cuneiform. So it's a series of back and forth going along the tendon and finally coming out from the tip of the tendon so that we have a nice hold within the tibialis anterior tendon. So you can see that I've got a fairly good hold on the tendon right now, and I put a small hemostat to hold the end of the suture material. The next step is to identify the lateral cuneiform, and this is best done under the image intensifier. It's usually in the line of the third ray, which is the center of the foot. And you can see that's the bullseye approach, as you can see, right through the center of the lateral cuneiform. So you take a dorsal incision now centered over that lateral cuneiform. The important structures to be careful here are the extensor digitorum longus tendon and the muscle, which is the extensor digitorum brevis. And you can see that I'm gradually opening the sheet over the muscle and then retracting the muscle laterally so that what is below that is the lateral cuneiform. I now make a small H-shaped incision over the periosteum of the lateral thick periosteum, which I can now elevate and bear enough of the bone so that I can see the lateral cuneiform bone clearly below. The next step is to make a drill hole through that, and there's a lovely study which came out from John Herzenberg showing 4 different drill inclinations. For those of you interested, it was the drill hole made to the center of the foot, which was the safest and provided the least damage to the medial and lateral plantar nerves. So that's my drill hole made with a 3.2 and then a 4.5 drill bit. And the next step I like to do is to widen and smoothen that hole by using a straight hemostat or a coker to get a smooth hole within the lateral cuneiform. The next step is to deliver the tendon between the 2 incisions through a subcutaneous tunnel. And I'm now, as you can see, releasing some fascial fibers so as to allow a straight line of pull so as to fulfill the requirements of a proper tendon transfer. This is an in-phase transfer, so there's no problem at all. Next is to insert the teeth needles through the hole made in the lateral cuneiform and bringing them out through the center of the foot, as we have spoken about earlier. So pull it out through the plantar aspect into the sole, and that's a safe area which is away from the medial lateral plantar nerves. I think it's important to ensure that there's a smooth gliding of the tendon rather than having the tendon bunch up at the entry of the into the bone. Ensure that it's gliding smoothly. And then with your assistant holding the foot in about 15 degrees of dorsiflexion, you tie it over a foam pad or over a gauze. And then check the final tension. And the best way to do that is to allow the assistant to actually let the foot drop, and the foot should actually fall into about 15 degrees of plantar flexion. The foot remains in dorsiflexion means that the tendon is too tight and you have to redo the tension in that. And then, of course, close the incisions and apply an above-knee plaster for 4 to 6 weeks. So this, in short, is the procedure for the tibialis anterior tendon transfer. I'll go ahead by reviewing a few important papers that have come out about the role of the tibialis anterior tendon transfer in a recurrent clubfoot. This is a paper that came out of Australia, which showed very clearly that they used a bunch of very elaborate tests using testing the strength using a handheld dynamometer, measuring the range of motion, foot alignment, and various scores. And they did prove that this tendon transfer was an effective procedure which restored the inversion to eversion strength and a good outcome with high satisfaction scores when you match them against a cohort of children who did not undergo the procedure. Another paper which came out from Lou Zions Institute, which showed a cadaveric model to test the effects of 3 different types of transfer techniques using either a 2-incision, a 3-incision, or a split transfer using 10 fresh frozen cadavers. And what they found that all 3 techniques were useful in providing various degrees of foot pronation, showing that the 2-incision technique was ideal, whereas using a 3-incision technique caused much more pronation and may be used when you have a more resistant foot. Besides the incision, I think it's also important where we insert the tendon into, and the recommended position, as I've shown you, is the lateral cuneiform and not the cuboid, which can result in a lot of excessive eversion and pronation, which is not what we want after this tendon transfer. This was an excellent paper that came out from Iowa, looking at Ponseti's patients treated between 1950 to 1967, 35 patients who underwent a tibialis anterior tendon transfer, and then followed up for an And these children underwent muscle examination, radiographic evaluation, and periodographic analysis, as well as some quality of life questionnaires. And when compared with children who did not require the transfer, showed that the mean ankle dorsiflexion was similar, though there was radiographically some small differences in the talocalcaneal angle and a little bit of taloflattening in the tendon transfer group. Overall, when looked at the peak pressures and EMG results and the outcome measures, they seem to do extremely well. So at a long-term follow-up, they showed that it was extremely effective at preventing additional relapse without affecting the long-term foot function in children with clubfoot. This was a paper which came out again from Iowa, from Morkwende, which showed that despite a tendon Achilles transfer, in their series, about 15% of patients can have a relapse even after the tendon transfer. And many of these children had some subtle neuromuscular deficits, and that's something we've seen in our practice as well. So doing a tendon transfer is not necessarily the end of the story. There are some children who have some subtle neuromuscular deficits who, despite a tendon transfer, can have a relapse. And therefore, these children may sometimes need to be braced even after the tendon transfer is complete. A final paper, which I found very useful, from Todd Milburn and his group, which showed that 20% of children in their CVs had a relapse, and the mean time to relapse was about 2 years, and showed very clearly that children who had the tendon transfer before the age of 2.5 years undergoing a relapse after the tendon transfer. And therefore, this proves whatever Ponseti said initially, that we should rarely do a tibialis anterior tendon transfer in a child who's less than 3. So the ideal age for doing this procedure is between the ages of 3 to 5 years. So in the time given to me, I have shown you the technique of the tendon transfer, the way I usually do it, and a few articles of literature which have shown the effect of the tendon transfer and some of the important points of considering the fact that children may relapse even after tibialis anterior tendon transfer. Thank you very much for your attention.
Thank you, Alaric. That was a very nice video and good description of technique. Any comments by any of the faculty members?
Yeah, thank you. Thank you, Alaric, for a great presentation and sharing your experience. One thing I would like to point out is, the position where we insert the tibialis anterior into the lateral cuneiform, not the cuboid. Why that was chosen also was demonstrated previously, I think in 1983, by another paper, which related to the axis of the subtalar joint. Because it is oblique, if you put it medial to the lateral cuneiform, it's going to be too close to the axis of the subtalar joint, will not provide enough lever arm for it to abduct the foot. While if you put it into the cuboid, it becomes too much. So Garciu actually initially put it into the cuboid and had a lot of excessive correction. So I think that's one of the things I wanted to highlight. And then the second question I had was, tensioning of the transfer is very important. So how do you guys achieve that, and how do you judge that intraoperatively? And also, any experience with using like a bio-absorbable screw to get interference fixation of the tendon? Thank you.
Sure. Thanks, Mohan. I think that was a great comment you made. I think the main reason we use the lateral cuneiform also is that it's perfectly in the center of the mid-axis of the foot. It's in the line of the third metatarsal, which is the central axis of the foot. And I think that's exactly what you want to achieve with a tendon transfer. You don't want to allow it to invert nor to evert, and you want to be a pure dorsiflexor. And therefore, the lateral cuneiform lends itself well to that. Your second point about how do you judge the tension, I would love to say we use 23 nanometers, Newton meter square of tension, but I think that's not the answer. I think a lot of it is just pure judgment. And what I do here is, as I've shown you in the video, I pull the tendon out through the sole of the foot and apply a small hemostat after tying a single knot. I don't really make multiple knots there. And then, as I've shown you, allow my assistant to actually drop the foot And if you see the foot falls down by around 10 to 15 degrees, that's absolutely ideal. You don't want that foot to remain in dorsiflexion. If that is the case, I loosen the knot up and I readjust the tension within the tendon so that the foot can actually fall down by around 15 degrees of plantar flexion, which is, I feel, the adequate tension. There's no way anywhere else you can judge the exact tension that's ideal after doing this transfer. Your final question about using other modes of fixation, I think, yes, of course, there'll be papers that have used interference screws. I feel that's, of course, expensive. It's not readily available to most people. Not many of us pediatric orthopedists, unless you're very much involved in sports medicine, are used to using interference screws. So throughout my practice, I've always used this pull-out suture. The sole of the foot has stood, the test of time. But I have absolutely no problems with those who use the interference screw in the older children, where the bone is really large enough to take the tendon and the interference screw as well. And there have been enough reports which have shown that the results can be equivalent. Thank you.
Thank you,
Alaric.
Ashish, I have a couple more questions.
Sure. Yeah, please.
So one question is, how do you judge how big a hole to make in the lateral cuneiform? Is it the same diameter as the tendon? Do you size your tendon and then make a tunnel that's what we call in line in diameter with the tendon? And the second thing was, have you run into problems on the plantar aspect of the foot? Have you had any issues with skin necrosis because of too much tensioning? What tricks do you use for that? Thank you.
Sure. So again, both good points. And as far as the sizing, I think, unlike the sports medicine guys are very particular about the tunnels and sizing of their ACL grafts, I think for us, we just look at the size of the tendon, see how wide we think it is. We know that, of course, in different ages, the thickness would vary. And it's always important to oversize the bone tunnel rather than undersize it. And of course, you have a way of going back again. If you're finding that your tunnel is too narrow in diameter and your tendon is bunching up at the entry hole rather than actually entering the entire tunnel, it's very easy to go back again and widen that using a straight hemostat, as I've shown you. So I don't really waste too much of time trying to size that hole. As I showed you, I begin with a 2.5 drill bit in the younger child, they size it up to 3.2 and then sometimes even 4.5 in the older child. And it's better to slightly oversize it rather than undersize it, as I've shown you before. The second question is about skin necrosis. Yes, of course, if you're not careful, you can get skin necrosis on the sole of the foot. But I think over time, each surgeon develops his own favorite method of how to prevent that from happening. I've completely avoided using buttons or anything which is hard, which is directly contacting against the skin. So as I've shown you, I've used a surgical foam and then a gauze piece over that. Until now, I've not had any skin necrosis resulting from that. I think using a stopper or using a button, if you contacted the skin directly, that can cause sometimes bad skin necrosis. So using surgical foam and a gauze over that, I found that to work really well to hold my tendon in place and at the same time avoid skin necrosis. Thank you.
Thank you. Thank you, Alaric. We have one more question, but we'll discuss about that a little bit later. We move on to the next talk by Atul Bhaskar about the treatment of relapse and recurrence after primary treatment. Atul.
I'll just can you see the screen?
Yes, it's visible.
My topic for today is the clubfoot relapse, and I'm grateful that Mohan and Hitesh has covered a lot of what happens post surgery, and so I'm going to cover what happens when the cast comes out, the brace is fitted, the child starts to walk, and the relapse pattern which is seen specifically following the Ponseti method. Now, we all know that children come into our clinic, either they can come during, the parents come with the antenatal scan, or they can come late, and anything in between. So the spectrum is huge. Now, whether the early diagnosis makes a difference, I think yes, it does in terms of treatment, the number of casts, as well as a child which comes at this age, adolescent, is almost will end up with a rigid foot. The kind of spectrum we see in clinical practice is children that have treated with Ponseti technique children that have had no treatment up to 2 years, resident clubfoot, which I think James will cover, and then the relapsed clubfoot. So these are clubfoot that have been treated with Ponseti and then come back with recurrence of one or more deformities after the commencement of the foot abduction orthosis. So this is a very, very specific relapse pattern which we see in practice, which was not seen earlier. And of course, the neglected clubfoot, and I don't think it's a bad word to use, neglected, because they have been neglected due to a variety of reasons. Could be accessibility of healthcare, affordability, acceptability. So presentation is delayed, but they're obviously neglected. So I don't think it's a wrong term to use, but my focus is on the recurrent or the relapse pattern following application of the foot abduction orthosis. Now, as already Mohan has alluded that, the reasons of relapse are several. Among them is, every surgeon wants to modify the technique to suit his or her needs. The foot biology is there at play, which certainly is not in our control. Bracing protocol and types of brace have been well covered by Hitesh. And finally, the education, parental education and social issues. I think this really is the big point, and I think Mohan has covered this very well. But regardless of the type of clubfoot, there's a strong tendency for the foot to relapse, and that is because of the biology, the collagen framework of the tissues, which if they're not kept into position by the brace, the tendency is to retract back up till age 4 years. And that's why this age 4 is considered to be like the golden age where you can start weaning the brace off. And why does the relapse occur? Again, there are no good answers. We know that some of the feet are very rigid to begin with. And really, when you start casting in the first couple of plasters, you come to know how this foot is going to behave. And there are some children where the tissues are extremely tight. They end up with foot edema. And even if the idiopathic, there's a biology against you, and you have to, judiciously apply a cast and also a bracing. So certain things are not in our control, but we can definitely control the casting position, the bracing, which can, sometimes help with the difficult clubfoot. Again, everybody has mentioned earlier, once the brace compliance collapses, the relapse starts. And this has been very well documented. In the absence of bracing, the relapse rate can vary from 28 to 68%. So we must counsel the parents that, maintenance phase is more important than the treatment. Many times when the last cast comes out, the parents are willing to celebrate that the treatment is over. And I tell them, no, that is now the treatment starts. And that is where the counseling part becomes very, very important, because many times, you tell them we put 5 plasters, 7 plasters, and you'll be okay. It's this part, I think one has to counsel at every visit when we put the plasters. And we've had some early publications in as early as 2006. We were one of the first to publish the role of bracing in Ponseti technique, the role of relapse, and how bracing in compliance can lead to relapse. And this was with an orthotist where we had reviewed different types of braces available in the year 2006. So this is a very old paper. Again, this has been well mentioned about brace problems, and typically I would counsel the parents when the child comes off the plaster, they visit the orthotist immediately. The orthotist will put a very, very tight brace without looking at the skin condition, and you get a call in the night that child has been crying because he's not comfortable. And now I really wait for about 12 to 24 hours when the cast comes out, let the edema settle down, so that there is no swelling in the foot before the brace is applied. And usually the brace is applied by me or one of my fellows, so that the orthotist doesn't know the amount of tension he has to give. And if you have different types of braces, you can get sores near the edge of the shoe, the heel stub which is crossing the foot, and sometimes on the lateral border. So this is and once you get this, the further chances of compliance becomes a question, because parents are not keen and they always want a newer brace. So it's important to checking out there's no edema in the feet, there's no swelling. See the feet yourself personally before you put the brace, rather than leaving it to the orthotist. Now the burden of relapse is immense, almost 70% relapse rate in the absence of bracing and 20% with bracing. But compared to the TKR, you see the bracing, primarily the relapse CTV is much high, and unfortunately it's not given the same importance as our colleagues who do knee replacement. They are raking much more money. So I always tell them that I'm doing a social service. Pediatric orthopedics is a social service branch of orthopedics, and Clubfoot is among them, where the patient satisfaction is more important. Now coming to our classification, so far no classification has been proposed for relapse, and there are various descriptive modalities where authors have used. So recurrence of any component of clubfoot after successful correction is called a relapse. It can be early or late if it comes within 2 to 4 years. The pyramidal Deshmukh score really cannot be used to measure relapse because there are too many permutations and combinations. There's a ceiling effect when you look at the empty heel sign, and the each score is not equally weighted. So it's really not a good score to use to measure relapse. Other papers have quoted as the relapse pattern as late onset, late worsening, unknown onset, early persistent. I mean, these are really confusing terms. One cannot use this in clinical practice, especially in patients who present late for Ponseti treatment. This paper from Crawford, which looked at relapses, they looked at minor and major relapses. So if a child requires a tendon transfer or a reed tenotomy, is called a minor relapse. And if he needs a full release, it's called a major relapse. And they had in their study 12 minor and 9 major relapses. So almost 40% relapse rate following a Ponseti technique from New Zealand. This paper from UK looked at relapse, and their definition was any recurrent deformity which occurs after the commencement of foot abduction orthosis should be called relapse that requires further treatment. So it certainly fits in the definition that whatever comes back, you need to treat. So it is relapse in a way. Again, after T-band transfers, there are been reports of relapse, and it was defined as presence of one or more components of the deformity. So really speaking, whatever recurs back, in the order of your correction, it was called a relapse. So we worked on that. We looked at the classification, and we thought that we need to have a common language to gauge all the relapses. And also after we commence the foot abduction orthosis, all components will not relapse at the same time. Okay, the relapses will also progress from being flexible to rigid, and generally they occur in transverse and sagittal planes. And most importantly, the duration and the fitting of the abduction orthosis will influence the relapse pattern. And based on that, we proposed our own classification. We looked at the deformity which corrects last will recur first. So equinus recurs first. The relapses are flexible to begin with, and over time, as the child presents late, they can get rigid. And this was our classification published in 2013, which goes from flexible to rigid, and we graded them as 1A, 1B, where there is decrease in ankle dorsiflexion, dynamic foot adduction, which are flexible relapses, moving to fixed deformity, fixed equinus, which is commonly seen following the orthosis, fixed adduction, and any 2 or more deformities. So this is a very simple way to gauge relapses in our practice as these children started coming back during the follow-up. And there have been some references to this classification. Of course, it's not perfect, but we had a few citations of this classification versus the other scores, the Ponseti and the Deshmukh score, the Pirani score. And we have about 40 citations so far. And we were one of the first to really look at relapse pattern of clubfoot following the Ponseti bracing protocol below less than 4 years. Of course, we could not assess the function at that age. It's not easy to do that below 4 years of age. There was a classification which was published from, I think, from Delhi, looking at similar findings of recurrence, equinus, adduction, loss of dorsiflexion, and then loss of squatting and Pirani grade 1. So, but this gets confusing as you try and remember these figures. Certain signs which are critical when you see these children in the follow-up is to look at the deep crease, the flexed hallux, the calf atrophy, and there are certain signs which will really tell us that this foot is not going to behave straight. And for me, the early warning signs are poor aorta function, persistent great toe flexion, poor finding of the toes on stimulation, dynamic supination, as Alaric has mentioned, and gradual inability to squat. And I always, in Indian customs, children want to squat. So I always test them at every visit whether they can squat without raising the heel. And that, I think, is one of the most sensitive signs to detect early relapses. And we sometimes you do these the wrist signs where you can see the toe is not extending at all, and there is poor reversion of the fanning of the toes, and these ones are a high risk of getting a relapse. So we looked at our classification where the relapse pattern was graded from mild to severe. So if there's loss of dorsiflexion less than 15 degrees as compared to a contralateral foot, or in bilateral club foot, if you can't get 15-degree dorsiflexion, it was considered to be as a grade 1 relapse, where you can start counseling them for increasing the duration of the splint or even plasters. And usually we find that once they apply the brace for a longer duration, or we can apply a cast, they respond. Very rarely we need to resort to re-tenotomy. Now, whenever you think of re-tenotomy, it's not a benign procedure. There's a lot of scarring because of the previous tenotomy. Either it has been done by a needle or a knife. There is scarring right up to the joint capsule, and sometimes it is not easy to get correction following this. So I would not hesitate to do a posterior release if required. Just a tendon lengthening in an older child, and followed by plasters and a brace. So this is what I meant by squatting. So we find children who can't squat, they are at risk of early relapse, and at every visit I ensure that they're able to do this. So this child is around 4 years of age and is able to squat. He's got good dorsiflexion, and hence will do well in terms of foot score. This is a controversial relapse pattern. This is dynamic supination, again very commonly seen because of the lack of duration of the brace wear, and it is here the heel is neutral, but as the child walks or stands, typically in standing you will see that the foot point inwards, and as they walk the great toe move inwards, and this is really very, very common. And I really emphasize this to the parents, that whenever you are putting the brace, after you remove the brace, do some stretching to the child so that you can make sure that you can abduct the foot to about 70 degrees. I think this video is not playing. Alaric already mentioned this. So if there is a dynamic supination in an older child, I would do a tib and transfer about 3.5 years of age. I also do in a younger child, I would do a cast. I would increase the brace duration, and I would also sometimes do what is called an abductor hallucis tenotomy. And sometimes I do it routinely now for children where I know that the forefoot looks abducted despite our 4 or 5 plasters. So this is a very benign procedure. Needs a short anesthesia when you do the tenotomy. And of course, there are no studies on this. So we are looking at our old patients to get some data. Grade 2 is, I think this is the most common relapse pattern I see in practice, where there's a single plane deformity and typically rigid equinus. And here the most common cause is the brace. Around 2 years, the parents stop putting the brace. So here you don't get any passive correction. The child cannot squat. And these are the ones where we would go ahead and do a recasting or a surgery. Now, there are times where you would get a fixed equinus, but you got a dynamic supination. So that's why you assess the rigid component first, and then the flexible component. So this child had a tenotomy done far medially, relapsed with an equinus, but the forefoot was completely correctable to 40 degrees. So you get this rigid pattern with a dynamic component, which is not unusual around age 2 to 3 years of age. And you look at the most severe deformity here and grade it accordingly. So fixed equinus, I've gone ahead and done posterior releases. Sometimes one may have to also do the capsule release, especially the syndromic feet, and cast them. So this child had a Z lengthening done. He was an older child, and you can see the scar there. And of course, following this, they need to wear a brace. And I also give them a nighttime AFO and a CTV shoe to try and give more splints and shoes, so the parents realize that this is the only surgery they will need. In case they falter, they will come back. They will need bigger procedures. So we can use sometimes a hemi-Cincinnati approach where you've done the tendon release, occasionally capsule release. If they're very tight, so on table they should get at least 15-20 degrees of dorsiflexion before you close the skin. Otherwise, they will again relapse, and you cannot do further surgery because there's so much scarring. They will always get a weak tendon. Grade 2 relapse pattern again is in coronal plane. So there is a fixed adduction deformity. Heel is neutral. And again, this is seen in older children, typically around 3 years of age, where they got, because of persistent supination, they get this curvature in the lateral border. And these ones, this is the child's mother who told me that when my son stands, I can see his slippers are slipping, and it was interesting. So I looked at a child with a valgus foot, and his mother complained that his footwear is not good. And this is how parents relate to us. They find that the footwear is not fitting, but they don't look at the heel. They don't understand the morphology of the heel, but they look at the slipper. So I call this the slipper sign. Typically seen in the Indian subcontinent, where you get this kind of pattern. Look at the hind foot very clearly on weight bearing, and then decide what is flexible and what is rigid. Older children with this kind of deformity, with the rigid curvature, we would always go ahead and do a pivot osteotomy with a tendon transfer. So they are rigid feet. I mean, they are not pliable. Some people would put 5 plasters, 10 plasters, but usually in my practice, I would go ahead and do a surgery straight away so that we don't, get too much stiffness in the foot. This has been well described, a combined transcuneiform osteotomy. So I think it's an a la carte approach. I would not do such a radical surgery for every child, but judge the correction based on their flexibility. So this is just a paper from Singapore, from James, where they've done this transcuneiform osteotomy. So grade 3 is a complete full-blown relapse where there is a deformity in all planes. And here you can start, with casting to get the skin a bit more supple. And then you can decide what surgery you want to do. That is entirely up to individual preference, how the foot responds to casting, how compliant the family is, what are the social circumstances. But from our study, we also looked at the cause of relapse, and we found that if you wear the brace for less than 8 hours, there's a high chance of relapse. So we had maximum relapses in children who wore the brace for less than 8 hours. So almost 40% of those will relapse if the brace compliance is poor and it's kept for less than 8 hours. So the key to, I think, the prevention is of relapse is bracing. We can use all kind of monitors. We can use sensors. Ultimately, I think it's the mother. The mother is the most important. And they always say this from the Consulate International, that behind every clubfoot kid, there's a great clubfoot mother. And if they can maintain the compliance, I think we will see less relapses following the Ponseti. And again, this has been well documented about the bracing. Neglected clubfoot or untreated, I think James Fernandes will cover this. I won't go into detail, but we guess children like these at adolescent clubfoot where we have to do the full-blown surgery. What we are doing now is looking at this paper from Sankar at gait pattern in children, and we've got a gait lab now. So we have started studying these children with unilateral and bilateral club feet, and we find that there is definitely a lot of intorsion, in-toeing, adductors, and it may be a way to then assess the children for relapses besides just having a simple clinical score. This is all research interventions for prevention of relapse, not currently in vogue. But in conclusion, I would mention that there are both intrinsic and extrinsic factors which will influence the relapse following the Ponseti. We need to have a protocol for every feet. If they're atypical or resistant, don't hesitate to apply plasters once the tenotomy is done, like an extended protocol. We need to have a uniform language to classify relapses. I think this is very, very important, since we're going to see more and more of this. And at the end of the day, every child is individual. Whether they will need a surgery, casting, bony surgery, is an individual approach. And I thank you for your attention. Thank you very much.
Thank you, Atul. That was a great talk, and thanks for sharing your classification, which is very useful. So now we will have some questions after talk by Mr. Fernandes. His talk, which all of us are waiting to hear. So may I request Mr. James Fernandes to give his talk on the treatment of multiply operated recalcitrant clubfoot and ILLRS journey.
Can you all see now?
Yes.
Yeah.
Thank you.
Sorry. Thanks again, Ashish, for asking me to be a part of this. Of course, we have done the part one the other day, and I thought I'll change my topic to the multiply operated, which predominantly what I used to see in my career when I first started in Sheffield, the recalcitrant and syndromic club feet. I know Atul mentioned about neglected club feet. I think it was already dealt with by Tim Nunn last week. So I'm not going to go into any details with that. So I don't have any conflict of interest. And I've shown you three examples here, a classical, atypical, and orthogrypotic. And each one of them, we know throughout this webinar that treatment will be slightly different for each one of these. But at the end of the day, we have two ultimate gurus. We have talked about Ponseti a lot. And I think he has changed everything for us with the management of Clubfeet. And in a different way, Elizarov has given us a completely different instrument or tool with the full knowledge of the basics and basics of histogenesis, how to use his Elizarov method. I think Atul has gone through all this. There are so many terminologies. We do not have any real classifications of these terminologies. And Alaric has already discussed about the residual, including the discussion about the tendon transfers. Atul has discussed about recurrence and relapse. And there are a few areas where in this recurrence, like he has mentioned, in individual deformities, you can deal with each one of them separately with some minimalistic kind of approach. The last three in that classification is neglected, untreated virgin feet. According to me, these are very easily treatable by the Ponseti method. Of course, ideal below 2, but now we know up to 10 years or even more from studies from Tim Nunn as well as from Brazil. I find a small group of recalcitrant resistant club feet. Usually they are bilateral and most of them are boys. And like Atul mentioned, the classic sign I find is the flat anterolateral compartment, which tells me that actually even the peronei are not working and there is a background pathology of some sort of low motor neuron pathology somewhere from the anterior horn cell or below. And the worst group of all is as multiply operated feet have significant scars and they have maybe infections, wound ascents, and so on. The soft tissues actually behave like bone. And you can see a good example of a foot on a podoscope, which we have in clinic. So there are quite a few other presentations we see, and these are all iatrogenic, secondary to surgery. So the dorsally subluxed navicular, or a bunched up midfoot cavus, the O-corrected clubfoot with significant hindfoot valgus, forefoot pronation, abduction, and the dorsal bunion, primarily due to significant triceps insufficiency because of over-lengthening and weak peroneus longus. And thereby the FHL and FHB are strong against an unopposed tibialis anterior. We looked at our own series here and saw that children who had joint laxity had a significant tendency for overcorrection. And this is something I suppose, which I suppose people should think about even in neglected or late presenters when you do a complete tenotomy to assess whether the children also have got hypermobility. I wonder whether you go and do a complete tenotomy, whether they will go into overcorrection. The other post-surgical complication is this one of these, which I've done recently. You can see he was a 16-year-old boy with kidney transplants and his gait was extremely poor. And you can see that the hind foot is in calcaneus, forefoot is pronated and significant toe deformities. Like we have all probably have agreed by now that the role for primary or revision surgery needs to be abandoned. I think these are all historical now, and limited posterior release or midfoot procedures may have a role. And there's a big Ponseti theme going on in the parent support groups, and everybody knows that surgery, we knew that it was very enjoyable when we did it, but it has got no future because of poor functional results. Quite a few of these other conventional procedures, an example was already shown by Dr. Bhaskar. I think Dr. Shingade showed a good series of his last week. And these are all can be done in select patients. In my practice, you can see these are the type of groups of patients I see, mainly used to be mainly multiply operated. Recently, some of them are multiply failed Ponseti, arthrogrypotics, the surgical complications of overcorrection, calcaneal cavus, and the adolescent deformed feet with pain, and the syndromic ones. What does more surgery do? More surgery is not better. It adds even more scar. Precise correction becomes difficult. In unilateral feet, the foot becomes significantly small. And as you can see in this child's example, bilateral, multiple previous procedures, severe deformities, and neurovascular problems will be a risk to go in and open them again. So external fixators are a real alternative. It's gradual, precise correction. We can control the rate. We can watch the neurovascular structures and the skin. We can do either soft tissue or a combined soft tissue and bony corrections. They could be staged, hindfoot usually what I do first, followed by midfoot. It allows ambulatory treatment. All my patients walk. We have in soft tissue distraction, you have to neutralize, which means that after you overcorrect the foot, which is very important, you have to keep the frame for another 3 months so that the soft tissues lose their memory being tight. And you can combine other things if you want to derotate the tibia in the supramalleolar level or lengthening if they're short. I know I've come to Mumbai and I've seen people using the Just Fixator. Just Fixator is very constrained fixator, and I personally do not like it in a way. The talar spatial frame also to some extent is quite constrained, whereas compared to the traditional ILLRS, you will see most of my frames, they all have got unconstrained triple hinges working at all points. There's lots of literature already. I'm not going to go through each one of these papers. And mainly these were all for relapsed club feet or previously operated club feet, including Drop Haley in 1993. From Sheffield, we had our own publication by Rachel Hutchinson with Prof. Saleh using pedography, which showed statistically significant difference in pressure distribution after ILLRS surgery. So what are the techniques available? So we have soft tissue distraction, and I've classified bony correction with U osteotomy, V osteotomies, which can be midfoot and calcaneal. You can use them for lengthening arthrodesis in painful deformed feet and tibial lengthening and derotation. In some of these, you are maintaining the length and therefore the benefit with the ILLRS of gradual distraction. Even though you might correct the foot to look like a foot, you have to balance the foot. So you might have to go ahead and do tendon transfers, whether they are split or total, and supramalleolar derotation. And if they already have dorsal bunions, you need to either use techniques of transferring the FHL or the McKay technique to correct all the plantar flexion of the first ray to get a good correction of the dorsal bunion. Soft tissue distraction is usually done under 8 to 9 years. It activates the circumferential physis to reshape, just like how the Ponseti method does. And we hope to achieve a new congruous alignment and maintains foot length. Now, Atul, Dr. Bhaskar quite correctly mentioned about percutaneous releases. He has added the abductor hallucis tenotomy, and I've been using it for a long time. In most of my cases, even the ones where I do serial casting, I will do a plantar fasciotomy, percutaneous. I actually resect the abductor hallucis and then apply a frame. And this produces quite a bit of correction as well as reduces the pain for the child during distraction. So until 2001, we were using the classic ILLRS technique of distraction. But in 2000, we started the Ponseti method in Sheffield. And suddenly I thought, can we use some of the principles in a modified way using the frame? So we have been using that. We're trying to do simultaneous correction using a strict regime. Just to show you all the motors, there are a total of 7 motors, 3 in the hind foot, 2 in the forefoot, and 2 in the plantar aspect, medial and lateral. They all have their individual things to correct. As you can know, on the forefoot ones, you can control supination and pronation. So therefore, you can keep the foot in a continuous supinated position, like how Ponseti describes. We use a talar wire depending on type of correction we're doing. If you're doing small children, I usually put olive wires on the lateral side, that is just small half-cut olive wires. Otherwise, it will be a complete talar wire. And then if you are doing bony osteotomies, accordingly, we will use the talar wire to start with when we do calcaneal distraction, so that there is no pressure going to the ankle joint. The talar wire is arch tension to reduce the force at the ankle. And when we come to do the midfoot, at the second stage, I put what is called saddle wires in the second stage. Just to show you an example without the leg here, and this is the final motor we apply on the supination pronation motor on a hinge, and then we start to rotate this externally to mimic the Ponseti thing of applying external rotation after tendo-Achilles tenotomy. The distraction goes according to law of similar triangles, remembering where the neurovascular structures are and following the Ponseti principles. Like I mentioned, at the end of foot comes plantigrade, we go into overcorrection into external rotation motor, which is applied. In a very small feet, I'll tell you very few examples where we have, you may wonder why we have done this. I'll tell you why. This is an Ilizarov small bone fixator. So this child was actually had 2 trials of Ponseti method. The father actually had schizophrenia, and the child was not coping with bracing, crying every night. The father actually had a severe relapse of a schizophrenic episode, and the mother came crying to me, "Can you do something else?" And so there are select patients where you might have to use, this looks like a grotesque technique, but this boy went on to have a real great result. So the same technique of using the Ponseti method, but just by using distraction. And he did not cry after that, apparently, in the night. When you do a U osteotomy, if a foot is uniformly supinated, there's a flat top talus and limited range of movement, then that's a great one for U osteotomy. I use what I call a book test. I put the book on the foot or any like a platform, and if the heel, the 5th metatarsal and the 1st metatarsal are all on the same plane, it means that you can correct the whole foot in one go through an U osteotomy, which I'll show you an example here. So you can see that this is an uniformly supinated foot. The U goes to the neck of the talus under the subtalar joint, and gradually you correct with the system, and new bone formation occurs through the talus and the calcaneum. And that's the end result, a plantigrade foot. Of course, it was stiff to start with. It will be stiff, but the foot is in a better position. You can see the flat top talus. I don't think we can offer much more than that. When do we use a V osteotomy? There has to be a dissociated deformity between the hind and the forefoot. So either the hind foot is in varus and the forefoot is in significant pronation, or your hind foot is in valgus, as in calcaneocavus, and your forefoot is pronated. It also requires a stiff subtalar joint. The foot can be lengthened, especially when it is unilateral, but of course it's quite painful. So we just distract a little bit more than usual, and that's it. Hinges are all set at apex of deformities, apices of deformities, or if they're quite complex in 3 dimensions, then we will use triple hinges, which you'll see in most of my frames. So the V osteotomy doesn't mean that the V has to be here. It can be a V here, as you can see, wherever the cora is, you can exactly put your osteotomies accordingly. Here you can see there's a hindfoot osteotomy done and later a midfoot osteotomy with a final correction. You might have to use, even after all that, if there is residual torsion. According to me, most of the deformity is all in the foot. If you don't correct the foot properly, you might think they got tibial torsion, but very few, I think the late ones which come to you probably will have some internal tibial torsion. So all these other things may have to be used with appropriate cases. It's just to show a multi-level combination of everything. In an older, but this was actually an orthogrypotic, is a ankle fusion with screws, but they at the same time using framework to lengthen and equalize. You can see how his calf and anterior lateral compartment looks like. Another example of bony correction. So in my journey, we have seen quite a few relapses in Clubfeet, which are very challenging. Publications say anywhere from 10% to 6%. And even in our own little audit of our initial part, when I was in at Children's Hospital, we had quite a bit of relapse, especially after surgery. So we thought we'd look at the outcomes of a relapsed Clubfeet using the new Ponseti principles modified into our frame. And we looked at from 2001 to 2007, excluded all the syndromic and arthrogrypotic feet. We used the International Clubfoot Study Group, ICSG evaluation, pedo paragraphs, gait analysis, and ask questionnaires, as well as patient satisfaction. There were just 27 feet in 16 children. The scoring, of course, poor is more than 30. In this classification, excellent is 0 to 5, good 6 to 15. And we had published pedobiography before, and we also had a few of these with the pre and post-op. Not all had, unfortunately, 11 had post-op only. A gait analysis of only 14 feet. And we looked at this, including the ask score, which is validated and quite reliable. So age at operation was 5 years median, and duration of follow-up also was 5 years, at a maximum of 8 years, and duration of frame was 5 months. The duration of frame, of course, usually is longer in soft tissue distraction because we neutralize it for a longer time after correction. And the score of the ICSG was 6 to 13, which is averaging 7, which is actually quite good in terms of results. Pain with activity was 4, and problems with shoe wear was 6 feet. These are also foot pressure studies. You can see how the yellow shows about normal values, green in pre-ops at each of those first, fifth metatarsal and heel, and how they have gradually improved after distraction. With gait analysis, we analyzed, it's very difficult to analyze the foot itself, but we found all feet, 14 feet, showed improvement in compensatory mechanisms, both in terms of heel strike, foot progression angle, speed, hip rotation, and pelvic tilt. In the R score, we got an average score of 75, the range was 52 to 100, and in our own predated series, untreated clubfoot average was 38, and from publications, the average for a child with musculoskeletal disorders itself is 75. Of course, you will have complications. Most of them are pin side related, 27 feet, all minimal. 1 needed IV antibiotics, 2 broken wires. 1 developed a transient phase of chronic pain syndrome. We didn't have any physical disruption, growth arrest, or joint subluxation in this series. Like everything else, you still have to do tibialis anterior tendon transfers, which went on to have 2 had supramallear osteotomy, 1 went on to have percutaneous CA lengthening, and we had 1 relapse of this cohort. Just a quick few examples with the timeline for each of them. As you can see, these are all multiply operated with significant scar. I don't think even if you do serial casting for a long time, you'll get this feet quite correct. And you can see their maintenance even at 7 years. Another child, September 2005, to a 4-year result there. And another one of a 7 years, as you can see. And another example, similarly about 6 to 7 years. Another one, even more severe previous surgery. You can see significant scar on both the medial aspects, and you can see the end result at about 8 years. So we concluded that our soft tissue distraction using this modified Ponseti principles gave good, reliable results. We had also audited a previous surgery, previous clubfoot cases before 2001, and we had significantly better results, and with minimal complications, and the patients and parents, especially the parents rather, had high satisfaction. We thought recently we should evaluate a little bit more. Unfortunately, we don't have many pre-op scores because many of them are younger children. I don't know how well you can compare when they're young to when they're older, when they're put on weight, and they already become more than 50 to 60 kilos. So we thought we'll use the ROI outcome score on patients with resistance TTV using especially when we had done adjunctive hindfoot and midfoot osteotomies. So it was a 20-year period. We included all the frames that we had done. We mailed the ROI score to the parents, and whoever did not respond, we did a phone call follow-up. And Roy score, I'm not going to, this table up here, it's very small for you to read. It's disease-specific instrument, 10 items, parent-led, mainly based on satisfaction, function, both about foot status, appearance, teasing, and so on, which are very important for adolescent kids, and mainly foot pain, walking, and heavy exercise. And there are good publications about this showing to correlate with health-related measures, and it is sensitive to disease severity and different treatment modalities. So out of the total 160 patients whom we have done, 46, a response rate of 24%. Ideally, I don't think anyone will get more than 33%. So this was the best we could get. One of the problems in the United Kingdom is when the kids become older and they go to university, we cannot chase them because they've either moved houses, and we cannot go to the GP because of what is called the GDPR regulations. We cannot track them. So mean age of these patients were 12.6 years, and most of them, as you see, were idiopathic CTEV. 41 was classical Ilizarov. We did have a few TSF. Mean time in frame was 112 days. The mean time in surgery to Roy score was 10 years. So if you look at this Roy score, if you see the satisfaction response, foot status quite good, appearance quite good, teasing reasonably fine, they got teased less. But look at what happens to being in the western part of the world, in the northern hemisphere, where everyone has to wear shoes because of the weather. This was one of the problems, and another was shoes light. So a lot of people had problems with shoe fitting and shoes light. And I'm sure in the tropical countries of Africa, and for you all in India, it may not apply to some extent because most of them are either wearing slippers or sandals. So there might be less of a problem, to be very frank. In terms of function, from pain, there was reasonably good responses. Walking, but look at running. They had quite a lot of difficulty with running, heavy exercise, and reasonably okay with moderate exercise. So to conclude, 76% of the patients were positive about the status of their foot, but the main concern was shoe fitting in 61 and shoes the children like at 59%. 2 out of 3 children have minor or no problems with walking. And again, I think main concern was regarding function is pain with heavy exercise and running. What about the group of arthrogrypotics? We reviewed a series from 1989 to 2000. We haven't reviewed after that. Maybe I need to review these. There were 15 Clubfeet in these, average age at 9 years. I would ignore the knee contractures there because few of them, of course, as you know, it's multi-level problems in arthrogrypotics. We had 7 with soft tissue releases or progressive distraction and 8 with Clubfeet with bony procedures. And out of these, as you can see, time in frame was 20 weeks for soft tissue correction. Time in plaster following that was 8 weeks. Just an example here to show you soft tissue distraction getting corrected and getting a plantigrade foot. And bony correction, we also had 1 ankle fusion, which I had shown the example earlier, and 7 were U osteotomies with soft tissue release and progressive correction. Average follow-up time was 36 months, and fixator was 17 weeks, which is not too bad in terms of 3 to 4 months. 5 of the 7 clubfeet done by soft tissue distraction did recur, whereas all the bony clubfoot corrections maintained. So arthrogrypotic treatment remains a challenge, and we feel that the bony correction of clubfeet in the older age group maintained their correction. Despite loss of clubfoot correction in the younger age group, after soft tissue distraction, a partial correction is achieved. Recurrence do occur, and I think long-term splintage is quite important, I think, in these group, in this condition. And my personal suggestion for many of these syndromic and arthrogrypotic feet, I think you need to neutralize the frame for a longer time after you corrected the foot or even overcorrected. What are the other examples of feet which we deal with? Severe HMSN, unilateral feet, where they were stuck, and if you had to do open surgery, we'll have to possibly take chunks of bone and the foot size will become smaller. And this is her feet at the end of frame correction by bony osteotomies. Another example is a tibial hemimelia. This is an interesting case. You can see that there is a Jones type 1 on the right side with no tibia. On the left side is actually Jones type 4 hemimelia. Interestingly, the surgeon who was initially treating was doing Ponseti for the left foot. So not all feet are club feet, though they look like club feet. Without understanding that this was a Jones type 1 where the talus is stuck between the tibia and the fibula, and this was being treated by someone who was quite leading in club feet treatment. So everything which looks like a, you don't have to, my analogy is about the hammer and the nail. So everything that looks like a nail, you don't have to use a hammer. So this one, we did supratalar osteotomy. As you can see, the foot is looking in by almost 90 degrees. We got the foot around with the talar-spatial frame, and then followed up when he was a bit older with the U osteotomy to increase the submalleolar height with that end result. Another example is Larson's. You can see here, he had severe deformities, including later on scoliosis, knee problems, and hip. As you can see, these were the final corrections after surgery on both sides. Now you might wonder, he's had a little more recurrence on his left, but we had to keep him in equinus because his knee had fixed flexion deformity as well. And he had a very limited range of movement at the knee, and there was nothing else we could do. So sometimes you may have to optimize your correction in this syndromic condition to the sagittal alignment at the knee, hip, and spine. So do not try to correct everything to plantigrade, then they're going to struggle if they have a problem higher up. A child with Vactal syndrome with other problems in the spine as well. As you can see, we corrected quite well, we thought, but he had relapsed again already after 2 years on the right side. So probably we might have undercorrected his right foot. He also had tendon transfers. This is just to show you a familial 3 generation where they have atypical stiff calcaneovalgus feet, and even on CT scan, they had coalitions. He had coalitions. So we used a frame. As you can see here, his hind foot is come quite well underneath the leg, and we have recreated the arch. I don't have his final pictures because he's just in plaster at the moment. So other syndromic conditions where you can use the Ilisarov frame is all kinds of rocker bottom feet, which come extremely late. Even in Marfan syndromes, overcorrected I have used in select few. Some of the severe unilateral spina bifida feet in walkers, and also diastrophic dwarfs who have been treated by a sort of Ponseti or open releases elsewhere, and they come to you. The only other condition one has to be careful with amniotic band syndrome. There has been one instance where the child has lost the foot and the leg because the Ponseti treatment was started too early before the band was released. So do kindly talk to the plastic surgeons and make sure the Z-plasty is done of the band before you actually try to do the Ponseti on the foot. I could not get that example today. Again, another one, not all are club feet. This child was treated somewhere north of London as a club foot. When I asked mother, they did say there was no crease at the hind foot or midfoot, but looked like a club foot. And they did 2 trials of Ponseti, and finally they were not going anywhere. They got an X-ray done, and then finally they sent to me, of course. This is Trevor's disease, epiphysealis dysplasia hemimelica. And if you look at the CT scan, half of the distal tibia, and if you see the talus all looking bizarre, it was very stiff and fixed in equinus. And I don't have the full pictures, but I've shown you the final. I did a talectomy, tibiocalcaneal fusion with lengthening, and as you can see, that's the end result. So just to conclude my talk, I'm going to tell you about our Sheffield experience of all clubfoot deformities and what is actually happening in the last 30 years in our database. So if you see the number of foot corrections, we got data right from 1988 here. You can see we were almost doing some 25 to 27 frames a year in the peak. And you can see gradually that numbers have come down. Similarly, soft tissue compared to bony osteotomies, if you see there's a predominance of bony osteotomies which came on little later on. I think these are all we are trying to correct most of the multiply operated feet. And as you can see now, these numbers have come down significantly. And last year, we have, or 2018-19, we have just done only 3 osteotomies. And when you compare club feet to syndromic conditions, you can see the graph. We started Ponseti in 2000. Of course, remember, most of our referrals are not only from our center, they come from elsewhere as well. And most centers in the UK now are using the Ponseti. And you can see the beautiful decline in the use of framework, especially in that group. The only group now which we are treating predominantly are syndromic. So Ponseti's influence has really changed our full demographics of treatment in club feet. So we have seen a gradual decrease, and in terms of syndromic feet, which I'm sure it'll be the same all over the world, they will continue because you will still have to use some sort of technique to correct these feet. So I think the future, there is no need for primary and revision surgery. I think it needs to be abandoned. The Ponseti method for the older child also, I think, should be practiced, which Tim Nunn went through very well last week. And I think the ILLRS surgery will be reserved only for those difficult and syndromic cases. So what's the final goal? I think this was what I think Dr. Aroojis was referring to last time. The final goal of getting clubfoot corrected is to achieve a pain-free, functional plantigrade foot with balanced motors. So it's not only the problem with the foot, it's also just like a bit like poliomyelitis with foot deformities. You have to balance the motors. And the end point of treatment should be when the child can actively dorsiflex and invert the foot. This was something what Professor Verghese Chako taught us when I was in Manipal in 1985 to 88. And I think this is what I usually do, which Dr. Bhaskar nicely showed in his video of stroking the sole of the foot in the child. I do not do a tat in everyone because some of them, the peroneus longus works, and for them I'll use a splat. So not all require, so not all club feet are the same, and not all club feet need a complete tibialis anti-transfer, though most of them do. But if you are going to become a limb recon surgeon, there are lots of requirements. You need a multidisciplinary team. You have to prepare the patient well, which Dr. Belthur nicely has mentioned about it, as well as Ms. Blakey, thorough pre-op planning. And again, we seem to be repeating attention to detail. And from my point of view, understand the pathology and apply the principles accordingly. And secondary muscle balancing procedures are of paramount importance. But like everything else, I have to say this, when all else fails, the ring becomes divine. Thank you.
Thank you. Thank you for a great talk, and thank you for sharing your vast experience. Because of lack of time, we will take few questions and we conclude there. So one question asked is, what is the higher limit for doing tibialis anterior tendon transfer?
Sorry. There is nothing like higher limit. It depends on when they come. And if they have had, if they mean that after ILLRS surgery, if they need to, if nobody has touched it before, I will still shift the tendon. Sometimes it'll just, if they're so stiff, it'll just act like a tenodesis rather than a primary dorsiflexor. Because either way, in its present position, it becomes a deforming force over time. So yes, there is no higher limit as such. You have to use it as a principle. If the ankle is working or got range of movement, you can use it like a proper motor. If not, it'll act like a tenodesis, and you are taking away the deforming force of supination.
Thank you. Another question is, what's your take on doing frames for feet which are insensate, myelomeningocele or previous nerve injuries?
That's a good question, because the important part is, if these insensate feet are in severe deformities, they get pressure points and pressure sores in all these areas. So however good you do with total contact cast, you still have to get the foot in the best position. So the few I've done, I've actually converted the whole motors into a flail foot, corrected the foot, and you will see that the ulcers disappear after that. And you just need good footwear or total contact footwear or total contact casts after that. So that's the most important thing. I think if you leave a deformed foot, they gradually will have significant problems with ulcerations. Yeah.
Thank you. Any other questions or anything else the faculty would like to add?
I had a question, Ashish, if I may.
Yeah, please.
Thank you for the great presentation. This is a question for Atul Bhaskar. Is there any role for, how do we predict relapses? Is there a role for like genetic testing in some patients? And is there a role for like evaluating social determinants of health? Have you done this in your experience? What are the other faculty's opinions? Thanks.
Mohan, I don't think there's any genetic test which can tell us about relapse, but I think in my follow-up, even when I tell my fellows is to every child when they come, just don't look at the orthosis, assess the feet clinically, and the subtle weaknesses in the eversion and a lot of dynamic supination. Those are the real signs where between 18 months to 2 years is a critical time where the child compliance decreases. The parents are not very happy putting the brace for 12 hours or nap time, and that is where they need the reinforcement. So I think the social signs, I've not really studied that between the social state of the parents, but definitely I think the biology of the foot one has to look at every follow-up. And if I find that the child is losing dorsiflexion at the visit, or if I find there's a lot of overactivity, I will not hesitate to cast them. Or if they're not putting the splint for more than 8 hours, I actually don't hesitate to cast them. I tell them I'll put a plaster just to improve the compliance, and so that they understand the importance of splinting. So that if you just leave them alone and say, okay, increase the duration, they will not do it. I think one has to be really sincere and tell them, no, I will cast this feet in the next visit. And that way, I think many of them will understand, and they don't mind putting a cast so that the compliance improves. So I look for early signs, really early signs of lack of eversion, loss of dorsiflexion in terms of squatting ability, and I will not hesitate to cast them early if they are under follow-up.
Another question for all faculty is, what are the indications for X-rays, and do you use ultrasound in your practice?
So I would only do X-rays if I'm planning surgery, in the sense of planning a bony surgery, or if there is during correction or during relapse, I find that the foot is not responding. So if there's any, or the patient has come from another person, has been treated, there's a lot of scarring, just to look at the bony changes. Sometimes the talus is flat top, there is a subluxation of the navicular, and you find if there's rocker bottom feet during correction, I'll do an X-ray. Otherwise, very rarely, I think during primary treatment, I would do an X-ray.
Okay, thank you. I think we had excellent session, and would like to thank all of the faculty members for sharing their knowledge and lectures, and would also like to thank the viewers for participating Sunday evening. Thank you very much. I think we end here. Thank you.
Thanks, Ashish.
Good
Thank
night.
you very much.
Thanks.
Thank you, Ashish, for excellent job you have done, and especially to Ashok Sham. I think whatever he's doing, I think he's got a golden touch with IT, I think.
Thank you.
Thank you,
Ashish, can I ask one question? How did you get Volkswagen to sponsor this session? I was looking at the sponsorship.